Good morning from San Francisco. I'm Ken Binmoeller. My thanks to Said and the organizing committee for the Birmingham International Endoscopy Symposium 2021. It's a great pleasure to participate, and I'm going to give a quick UEMR update. It is over a decade ago now that I happened to discover during one of my routine endoscopic ultrasound examinations of a polyp in the colon that the muscularis propria on the outside remains round. It stays round despite the contraction of the mucosa and the submucosa in the lumen. So endoscopically, we see the folds of the mucosa and the submucosa contract, but the muscle layer on the outside stays round. And you see this illustrated in this video. Here on the left, there's our mini probe. You see the contraction of the lumen, but that muscularis propria on the outside stays round. It does not follow the involutions of the mucosa and the submucosa, even though the entire lumen may be contracted. And it's then that I realized that when we're underwater, we get a floating effect of the mucosal structures and the submucosal structures, as well as a contraction of the lumen, and these mucosal and submucosal structures also contract. The wall itself retains its native thickness, and the MP stays round after water immersion. So the wall thickness is somewhere in the order of between maybe 3 and 5 millimeters. But when we distend the lumen with gas, we thin out the wall thickness to about 1/3 of that diameter. So it's just a couple of millimeters that we're dealing with. And this is the reason why we perform submucosal injection to counter that effect. So when we go underwater, we get a floating effect and a contracting effect. And this floating effect is not just the absence of gravity. It's actually a true floating effect because the submucosa contains fat tissue. That's why on EUS, it's the third layer. It's echogenic. That's the fat in that layer. So it truly floats. We retain the native wall thickness and its consistency. That's important because when we inject into the wall, we change the consistency, we increase the tissue tension and decrease the compliance, and we preserve the wall layers. And this enables us to capture a larger surface area, achieving in a very high percent of cases en-bloc resection. And that should always be our goal, en-bloc resection. So we see this nicely illustrated in this video, a large granular type LST in the cecum. This measures over 4 centimeters. And now with the underwater view, you see how everything is now contracted. The lesion is contracted. I like to make some diathermic markings around the perimeter. I used to use APC. Now I just use the tip of the snare. This is the largest snare we have available, 33 millimeters, but it is able to completely encompass the perimeter of this greater than 4 centimeter polyp. Now you can see the appearance after the resection. Note there's no bleeding because the plane of resection is more superficial. It's an SM2. Here is the specimen pinned to some cork. It's a tubular villus adenoma. And here the appearance at 6 months of follow-up. So it's really impressive how by just filling the lumen with water and allowing the lumen to contract and that muscle stays on the outside, that we're able to capture much more real estate, a much larger surface area. And so I published results of en-bloc resection using the UEMR technique for large 2 to 4 centimeter colorectal LSTs back in 2015, 52 patients, and the en-bloc resection rate was 55%. Now, we were really just trimming the edges when we couldn't achieve en bloc resection. So the goal was en bloc, but sometimes we had some residual on the edges. This, I think, is very different from a piecemeal technique. Here it's en bloc attempted with trimming if there's some residual on the edges. Our recurrence rate was only 5%. Our results were later validated in this meta-analysis of 508 lesions, 10 studies. The en bloc resection rate overall was 57%, the complete resection rate 96%, and the recurrence rate somewhat higher than our 5% at 8.8%, but obviously a very good, very low recurrence rate. So now we have randomized controlled trials, 2 and a third that is now in peer review, that are validating our ability to achieve a significantly higher en bloc resection rate using the UEMR technique compared to the conventional. So this first study from 2019, 210 lesions, 5 Japanese centers. Now these polyps were intermediate size, 10 to 20 millimeters. And the en bloc resection rate using the UEMR technique was 89%. The conventional technique had an en bloc resection rate of 79%. So that's still pretty good, but this was still using UEMR significantly higher. The R0 resection rate was 69% underwater and 50% conventional. We now have from this year, from a group in Austria, a comparison of UEMR and conventional EMR for large 20 to 40 millimeter polyps, a total of 158 sessile or flat colorectal lesions. And here you can see in the blue, the conventional EMR technique. You can see the submucosal injectate here. And in the maroon, the UEMR technique without submucosal injection. The en bloc resection rate for 20 to 40 millimeter lesions was significantly higher for the UEMR group compared to the conventional. The R0 resection rate for 20 to 40 millimeter lesions, significantly higher for the UEMR group. And the recurrence rate for 30 to 40 millimeter lesions, so those are, maybe we can call these giant, was significantly lower in the UEMR group, only 6% compared with 43% in the conventional group. So these are very impressive results. We took the lead in an international randomized controlled trial, and the paper has been submitted for peer review comparing conventional and UEMR, 303 lesions, all LSTs larger than 15 millimeters in size, with a mean of 3 centimeters in both groups. 4-center trial, and 1 center in Italy, and the other 3 in the US. So the en bloc resection rate was 48% in the UEMR group, which is nearly double, or actually double, of that of the conventional EMR group, statistically highly significant. And the need for additional ablative techniques was significantly lower in the UEMR group, 11% versus 27%. When we look at resection time, 11 minutes mean for the UEMR group, 17 for the conventional, highly statistically significant. And the total procedure time was also significantly lower in the UEMR group. Delayed bleeding and perforation rates were similar in both groups. But if we look at the residual adenoma rate, it was half that in the UEMR group compared to the conventional. So 8% versus 16%. Now this was just short of statistical significance, and I think is a type 2 error because of the limited patient number. I'd like to share this very interesting paper from this year from the Osaka International Cancer Institute comparing UEMR with ESD for 20 to 30 millimeter colorectal polyps. The UEMR en bloc resection rate was 61% for these large polyps. Now, of course, the ESD resection rate en bloc was 99%, not surprisingly, but still an impressive 61% resection rate. But notably, the resection time in the UEMR group, 6 minutes compared to 60 minutes. Now, these are highly skilled Japanese endoscopists that can do this in 1 hour, but it was 1/10 of that time using the UEMR technique. Notably, the UEMR group had no recurrences. Now, it's not surprising there were no recurrences in the ESD group when you achieve en bloc resection, but the outcome was the same. Bleeding rates similar. They concluded that the sample size was sufficient to prove non-inferiority of UEMR versus ESD. So clearly, a randomized controlled trial comparing UEMR with ESD is warranted. So to summarize, comparing UEMR and conventional EMR, there are 3 randomized controlled trials, 1 in peer review now, all showing a higher en bloc resection rate and higher R0 resection rate, faster, significantly faster resection time is money, and a lower recurrence rate for polyps larger than 3 centimeters in the Austrian study, and very close to statistical significance in the international trial that's in peer review. UEMR was found to be equivalent to ESD for large polyps, and we wait validation in a randomized controlled trial. So thank you very much for this opportunity to give a quick update on UEMR.